Hello, and welcome to Tackling Training Barriers in Maternity, ED, and Intensive Care, presented by representatives with Laerdal. Just a note that this session is being recorded and will be uploaded to the online learning section of the SSH website by the end of the week. By attending this webinar, you agree to receive follow-up communication from Laerdal representatives. This session is part of the Fall Virtual Learning Lab series, hosted each Wednesday at 2 p.m. Eastern by members of the SSH Corporate Roundtable. During this session, we ask that you keep your cameras off unless otherwise instructed by the presenters and direct all questions through the chat. With that, I will turn this session over to Janet Tamburini with Laerdal.
Olivia, thank you so very much. We appreciate that. And good day, everyone, and welcome to today's webinar. We are delighted to have you with us. My name is Janet Tamburini, formerly the Healthcare Segment Marketing Manager at Laerdal Medical, and I'll be guiding today's discussion and moderating this session with our distinguished guest speakers. So first, I would like to introduce you to Dr. Roxanne Gardner, who is an assistant professor of obstetrics and gynecology at Harvard Medical School. She also works in the Department of Obstetrics and Gynecology at Brigham and Women's Hospital and the Division of Gynecology at Boston Children's Hospital. Dr. Gardner is a member of the Harvard Medical Faculty Physicians at Beth Israel Deaconess Medical Center and its Department of Anesthesia and Critical Care and Pain Medicine. She is the Executive Director and Director of Simulation Fellowship and International Scholars Program at the Center for Medical Simulation in Boston. Welcome, Dr. Gardner.
Thank you.
We are also honored to have with us Dr. Lon Setnick, emergency physician at Littleton Regional Hospital at Littleton, New Hampshire. He is the Director of Clinical Programs at the Center of Medical Simulation in Boston and part-time lecturer on anesthesia at Harvard Medical School. Additionally, Dr. Setnick is the Clinical Assistant Professor of Emergency Medicine at the University of New England College of Osteopathic Medicine in Biddeford, Maine. Welcome, Dr. Setnick.
Great to be here. Thanks, Janet.
We are just absolutely delighted to have both of you here and to lean into your expertise. We can't thank you enough. I'll just kind of set the stage here for what's going to transpire in just about under an hour here. For the general overview, our agenda, we are going to share practical insights on readiness goals and learn how to harness interprofessional teams for real-world readiness, identify risks, gaps, and vision for listening partners, and identify and tackle training obstacles or barriers. And within these strategies, the goal is to create a sustainable solution that strengthens the overall clinical preparedness. But before starting, I'd like to, for a little indulgence here, if you don't mind, with a quick note about Laerdal's mission. So Laerdal is deeply committed to helping save 1 million more lives every year by 2030. It's a goal that continues to guide our work. And through global training programs and impactful partnerships, we have already seen meaningful progress, including millions of bystanders, students, and professionals trained and thousands of lives saved annually. To learn more, we invite you to click on the URL or the link above on your screen. And with that, let's kick off this discussion with a story and have Dr. Lon Setnick take it from here.
So you are the simulationist at a regional center, and your hospital is affiliated with a smaller hospital which just closed its OB unit. And you've gotten a request. Hey, can you come run some sims so our department can be better at managing OB emergencies because now we don't have OB? Or maybe you're a nurse educator and you have just gotten a huge cohort of new grad students and you've gotten a request. Hey, can you run some sims? Because we've got a bunch of new grads coming onto the OB unit. We had a lot of departures. And so the question is, when you get this request, how do you think about it? How do you build sustainable solutions that actually make real world readiness happen?
Thank you for that. You both use the word in the agenda and there, Lon and Dr. Gardner, about readiness and readiness goals in lieu of the word objectives. Could you elaborate on this change for us and really describe what readiness looks like to you?
Yeah, Rox, I can take that. The reason why we're using the word readiness instead of learning objectives is because one of the things that holds us back from long-term sustainable goals and long-term sustainable partnerships is the idea that what we are doing is, quote, educating people. And instead, what we're trying to do is meet organizations and units where they're at in terms of their real world situational readiness. What are situations that they face, and how are they going to be ready for those situations? And when we use the word readiness, it unlocks a partnership as well as a psychological ownership. Um, when we use education, we as the educators are the owners of whether somebody has achieved the goals or not. But when we use readiness, it's the participants who own their own readiness. And that psychological ownership shift away from us owning it to them owning it is one of the keys to creating sustainable solutions.
Wonderful. That makes sense. And on the next slide, in continuing with the idea of readiness, there's another question that I'd like to pose, and it's why and how did your organization transition from individual learners and departmental training to a more and intra-professional team training?
Yeah, Janet, thank you for that question. I want to sort of take everybody back a few decades. I don't want to say how old I am, but I've been around the block. And I would say the mindset then was probably more around uni profession training and maybe a little bit more skills oriented and not really the notion of the concept of the team should really get together and train. And so that was where I was sitting at the point at which I entered simulation-based education, was exposed to all these concepts. So in 2001, I made a big transition within myself from thinking of individual or uni-professional type training to more of a team training. And I was initially involved in anesthesia crisis resource management, and that involved, it was uniprofessional in terms of the participants, but the other members of the team were represented, within the operating room or the PACU. And it just seemed to make so much sense that, we get together, all of us across our professions, and we have something to offer each other. We have something to learn from each other. We can appreciate, how we can zig instead of zagging and go smoother in a better direction to achieve a better outcome. So that was how my mindset got trained into the notion of the interprofessional members of the team coming together. And for labor and delivery, we're all together for so many hours, especially during your residency training. So just having your nursing member, your anesthesia member, your faculty members, pediatric members be part of what you're going through and learning how to improve just made so much more sense. Moreover, I think I just wanted to highlight that interprofessional team training has really taken root within across the educational discipline. And there is a role still for uni-professional training and individual procedural skill training, obviously. But I think, again, it depends on what is it you're trying to be ready for. Mm-hmm. And that's how I hook back to and align myself with some of the things that Lon just said that were so critical.
Wonderful, thank you. And I'm not sure, I would love if you could explain a little bit more on what you've outlined here. I'm not sure if my specific question really addresses and outlines this slide, but I was really curious about leadership buy-in, because you talk about buy-in there, and it's a critical component to a very successful simulation program. So how do you identify and overcome these leadership-related barriers with competing priorities to ensure a very sustainable program? So whether that leads into this discussion here or at the beginning or the end, I would love to learn more.
Oh, it's such a great question, Jen, and I think it really dovetails well with all the things that Roxanne was saying. One of the challenges we face is that leaders put our sim programs in the same bucket as other compliance-based, quote, education modules. And they can unfortunately be a little bit blind to the real benefits of interprofessional, interdisciplinary, and even what is called now sometimes transprofessional training, where you have the entire team participate. And one of the key mindset changes that we hope to promote is to help leaders understand that teams are more than just the sum of the individual skills of the people. It's how people interact together in their real environment that determines their context-specific readiness. And if we can help our leaders to see the difference between what we provide and what compliance modules provide, for example, oftentimes by them in some ways experiencing it themselves, they can then start to see the value of how what we do is different.
And on this slide, you speak not only about the awareness and trying to find the strategies, but it's being aware of some of the pitfalls. And you've outlined here, I'm not sure you've covered all of them.
I can walk us through this slide, which is really helpful. I think that's what you're saying.
Yeah.
Thanks. Okay. So as simulationists, we make some assumptions, or this is what we have seen, and you know what, some of my colleagues are on this call and they know I have made these assumptions myself. And so these are battle-worn learnings that have taken place. So we get called to run some sims, and we think that if we design the right sim, we will get training impact and we will get buy-in. And you know, in actuality, we are simulationists oftentimes because we enjoy sim more than anyone else in the organization. And so we make these assumptions that, hey, if I design the right case for this team, then we will get the outcomes we need. We also assume a set of priorities that are shared between us in the sim team, in the sim program, and in the unit themselves, in the unit leadership and the unit-based staff. And we can especially fall victim to this when we are actually employees within that unit. We think, oh, well, I work there, so I know what the goals are. But oftentimes, leadership has a different set of priorities, and those are hidden to us. And only by partnering with both the leaders and the ground level people to discover what are their real risks, what is their how do they see the risks to the organization? And oh, thanks, this is a great segue. So how do the leaders view the risks to patients? And how do they view their risks to the organization? So a lot of times departmental leaders view risks differently than frontline participants. They see risks as ending up in the newspaper or ending up on you know, the 5 o'clock news. And when we can find out what our leaders really care about, maybe it's staff turnover, maybe in your particular situation, the leaders have to report up the chain of command what they're doing to narrow the gap between underserved populations and other populations. And so when we can find out what the leaders really care about and what they view their risks are and what their visions for their department are, and we can help have that conversation, that will unlock what they care about, and it will help leverage that for our training process, our resources that we need to do the trainings, and then also how we're going to measure our impact. And we can feed back to them what they care about. We also need to do the same listening process with partners for the ground level staff. So as we pilot our program, we find out how did it land on them, what gaps are there in their training and their readiness, and what would their vision be? How would their world shine when we achieve our goals? And so when we can hear their risks, hear their vision, and help them understand what the gaps are between those two, and we do that with both the leaders and the people working on the ground. Our job then is to tailor our training to try to close some of those gaps within the department measurably. And then we get buy-in because we've achieved what that department cares about instead of what we think is important.
And Lon, I don't know if you happen to see in the chat, but somebody had mentioned, what about the concept of not enough financial resources as a major gap? And again, from the leader perspective, understanding what is their pain point, what are they concerned about, maybe an aspect of the training or an outcome that we anticipate for the training can help to save money on the front end and then be able to be used to further support the training that goes on. But there, those are substantial issues, those finances.
Yeah, I totally agree. Where the money comes from for the simulation program is a great question. It's not just the cost though, it's what costs are avoided by doing
Right.
simulation. And
Exactly.
sometimes that is reportable events that cost the hospital money. Sometimes that is meeting certain measures that cost the hospital money if they don't achieve those. And so when we find those out by partnering first and designing second, then we can start to get the resources needed for sustainable programs.
Exactly. And then to further highlight that it may not be just to the hospital, but to the healthcare providers directly in terms of a malpractice claim that gets matriculated through and is multi-million dollars worth. But the impact of that, if you can mitigate that issue from matriculating all the way to that point, then you have a way of mitigating provider trauma, lack of confidence, maybe a desire to get out of the whole field that they're practicing in. So there's a lot of ways to look at how we can impact our bottom line through training.
So true. I just want to point out one other really great comment. Sometimes you don't know until after you've done the sim what the gaps are. Um, and that is such a great comment because in that case, we're partnering in order to discover what the real gaps are. And that in those situations, our job is to be a listener in the debriefings of what people's real lived experience is and where do they find their gaps. But if we do that, we have a responsibility then to try to help close those gaps.
Mm-hmm.
So, do you have certain approaches that you found to be more effective in engaging senior leadership in some of these the training programs that you're discussing?
Yeah, Lana, I'll go first and then you can expand. Okay.
Okay.
I think we've highlighted, or alluded to some of these first bullets: priority, leadership support, engaging healthcare providers at the unit level, and overall, we're promoting a culture change, a change to becoming more of a learning environment, a change towards becoming a more resilient environment, and a change to becoming a more collegial, mutual support environment. And those things do take time, but going back to the partnership that you have you should reach out and establish with senior leaders throughout the unit that you want to address. What is your target population? Even up to the C-suite, getting to understand more some of what is going on financially that's really keeping people up at night, or what are they worried about that's happening in the hospital over and over and over again. And understanding their pain points gives you a better launch pad for creating something that will help mitigate that situation.
Yeah, I can't endorse enough this idea of trying to understand other people's pain points. So often as healthcare providers, we are in our place of work, we're in the middle of our day, and we live the repercussions of decisions that were made many layers above us. And we think, what are they doing? What are the leaders doing? Right? And and we have this saying at CMS, which is when you think WTF, and this is from Susie Eller at Stanford, or just leaving Stanford now. But when you think WTF, you want to transform that into what's their frame. And so when you are the recipient of decisions that are hard to understand, the solution is going to find out why they were made and what were the drivers for that. And that will help you to understand what the real pressures on the senior team are. And when you go to the senior team, not with a request for money so that you can do trainings, but instead with a question of what's keeping you up at night and how can I be somebody who helps solve your problems? I have this great team and we're capable of doing so much. And so what are the problems that you're facing on the OB unit or on in the ED? And oftentimes what you'll hear are things like, well, staff turnover and vacancies is making us crazy. And then you can potentially start to address those and say, hey, if we do more trainings for this area that people feel is a really risky area for the department, then people will feel ready for these moments that they're going to face, and they won't want to leave the hospital because they don't feel exposed. Instead of feeling that they've been abandoned by the parent organization by the withdrawal of funds for OB, they'll feel supported in this transition to a new world. And so you can help be a part of solving that staff turnover problem, for example. And now you're a problem solver for the leaders instead of a requester of resources, which is something they get all day.
And then, Lon, connecting back to, the real world challenges, one of the stimulus for this whole topic was the fact that we are losing obstetrical care services in many communities across the United States. And one statistics I came across is that more than 2 million women of childbearing age live in what they call maternity care deserts. And I've heard other authors counter the use of maternity care deserts and just call them what they are, which are areas without maternity care services available.
Yeah.
But however, which way you look at it, the fact that hospitals, our rural hospitals are closing their obstetrical services, it doesn't mean that an OB patient won't be coming to your hospital sometime soon where you don't have any obstetric providers. So figuring out a way to get your staff ready to deal with some of these precarious or acute situations. And it's not just necessarily confined to the emergency room, because it may involve an issue that needs to be taken to the intensive care unit and managed for a while before transfer. And so I was wondering, Lon, if you could talk us through some of the experiences you've had with your rural community in doing some team training and skills training and being ready, getting your staff ready for these types of situations.
Yeah, this is exactly the situation that we faced at one of the hospitals that I used to work at, and we in listening to the scope of the problem, what we found was a big part of the solution, which we hadn't expected, was actually training EMS providers. Because it used to be that the local EMS would have, a 5-minute transport time to the local facility for receiving a patient with an obstetrical issue. But now EMS has a 45-minute to an hour transport time. And so what we thought was going to be the training needs for the emergency department turned out to be the training needs for the emergency department and the EMS agency. And once we recognized that, we were able to understand the scope of the issue and then figure out how do we allocate resources so that we do serve that community appropriately. And knowing that the EMS agencies were also trained helped to reduce the anxiety in the hospital, because now they knew that the EMS would take the patients to the closest appropriate facility instead of to them. And so that was an example of like listening to, as somebody, as Lance Bailey said, stakeholder analysis is trying to understand actually the real scope of the problem, and then you can start to understand how you're going to address it.
Yeah. I was just thinking in I was just thinking back to some situations I've been in, the 45-minute drive to get someone to where they need to be may not just be a simple 45-minute drive. It may be a drive through precarious mountains, through terrible weather. So situations can accelerate to an even more acute degree by the time they actually get to the facility. And that sort of brings me to the idea of, well, so, thinking back to the finances, you might not have money to have very fancy mannequins. You had given some ideas about materials you worked with on the fly in doing some
Yeah.
in situ drills to try to get people ready for a variety of things that are very rare but can happen. And I was wondering if you could expand on that.
Yeah. So I do work at a rural site. We do have OB, but they're not in-house. And we have surgery, but they're not in-house. And we have anesthesia, but they're not in-house. And the emergency department team after 10 p.m. is one doctor, two nurses, and one tech most of the time. And so we actually ran a in situ simulation on a resuscitative hysterotomy, a perimortem C-section recently. But we did it with just a sweet potato in a pillow. So it was 1 in the morning and we had no patients and we decided to do some training. So we took a pillow and cut a hole in the bottom and put a sweet potato in it and put it in our resuscitation bay and said, oh boy, this is a patient who just arrived in cardiac arrest. They're going to need a resuscitative hysterotomy and we're going to need to do it. So what equipment should we use and what would the steps be? And we ended up with a very successful sweet potato delivery. And I will say, and one pillow went in the trash. But I think in terms of the cost of running a simulation, it was pretty cheap. But it got us a lot of the way. And so I think sometimes one of the challenges in simulation is that we love our equipment, we love our patients, our plastic mannequins, and we love our tools, and some of them are phenomenal. But we don't always need them. And sometimes Monica's asking, why did I have a sweet potato? I love sweet potatoes. I usually have one in a backpack as a snack. It's a great question. So we don't always have to we don't always have to do such detailed case creation if we can just have a way to model how we're going to work together as a team, what's our equipment, what are our resources, and that actually doesn't take much. There's a lot of work being done now on visually enhanced medical simulation VEMS, which just requires a paper cutout of a patient, and so I would say the majority of the sims I run right now in my organization are done with a pillow, plus or minus a sweet potato.
Well, you have to be creative, and we applaud that. And
Yeah.
Laerdal feels the same way.
Yeah.
Most people here on this attending would know that we have a phenomenal high fidelity simulator named Mama Ann. She's remarkable and can do so many things with outstanding and efficient turnover and variety of simulations. She is the be all end all, and yet we know at Laerdal that we need different solutions for different resources, different locations for any other number of reasons, which is why we have this kind of a stratification of solutions, whether it's prompt flex and VR. We have a number of things, including something that a lot of people still don't know about. It surprises me, maybe because we're about the only one that does this, is we do simulation as a service. Laerdal brings the equipment on site and does all of the training and provides all of the content and then leaves and can come back at your whenever you need. So it kind of mitigates the need for capital equipment or some of the other expenses in there. So there's a solution for everyone. But I'm going to go back to also what you were saying too, is you were acknowledging the various departments that are in need of whether it's the maternity deserts. I was trying, Dr. Gardner, to use your other term that is being used, rural facilities without the programs, without a labor and delivery program necessarily, but it's everyone. And it's almost as though you have to take that holistic view and look at a system-wide approach to simulation, not just a department, not just the stakeholders, leaderships, and partners, but a hospital system involves so many more.
And Janet, I think that would be a good segue to the readiness planning worksheet, which I think is the next slide, if I remember.
Do you mind advancing, Helen? There we
go. Yes.
The
okay.
one with the lines.
Yeah, this is it. So, so the question is, how do you have these planning conversations? And so, in the article that the infographics are from, which is on readiness planning, what we recommend, and I'll just have you go back to just showing just the middle column. So it'd be like 4 tabs back. What we recommend is actually just taking a piece of paper and co-developing a readiness plan with the department that you're serving. And one of the great ways of starting this conversation is just what situations might you face that you're not yet ready enough for? Okay. And so we might have a conversation with this hospital that has recently closed its unit of what do you need to get ready for, and we come up with a list of situations, and then we can work backwards and ask, what are the skills required to be successful in those situations? And if we tap one more forward, then we have a list of foundational skills that support situational readiness. And then what systems do we have in place that will maintain our readiness? And how can we build those systems out? So if we tab forward one more time, we can start to draft a continuous readiness plan year 1, for example, for this unit. And we might decide we have enough resources to provide 4 foundational skills training and 2 situational skills trainings for the first year. And so then we can start to ask, well, what should those be? And this is a co-creation tool. So this is, we call it a transitional object. It's a way of us communicating with our partners, okay? And co-creating the training program. And so what would those foundational skills trainings be? If we tab one more time, because we can't do everything, we're going to have to make some decisions. And so we always start with too big a plan because we're trying to fix everything. And we're going to have to make some decisions. And we might decide that, well, we can do 1 hour of foundational skills training 4 times a year, and we're going to focus on term vaginal delivery, the transfer process, and PPH. And then what situations should we focus on at the beginning? So we can tap again. And that would be normal delivery and PPH. Okay. So now we've got our first year readiness plan program outlined. And then what processes are going to be in place to help us understand the impact of our training? And we can co-create a debrief process for all the deliveries. And any delivery that takes place at that organization. And we can even have our situational readiness simulations debrief process be the same as our debrief process for the real world. And so the participants start to get used to what is it like to participate in these programs, and how does this department learn how ready it is and where the gaps are. And the ownership of the results of these lives not with the sim team, but with the department. And so we are kind of the facilitators of the department's activities. And so we have to continue to be in contact with them. How is it working and what have we learned?
Yeah, and Lon, I just love that you walked us through that for OB emergencies. And I'm sure similarly, you can have a similar plan for what would take place in intensive care unit settings and other settings across the hospital system. One of the things that one of our participants here brought up in the chat, Josie Scott, she mentioned doing tabletop exercises. And I think that's brilliant. I think, simulation comes in it's a technique, not a technology itself, per my godfather, David Gaba. And, there's so many different ways that you can go about doing these kinds of things. And, depending upon what resources available, are you doing this out of a labor of love, or is someone able to give you some kind of subsidy for the time that you're spending and other people are spending? It just depends on what is the nature of your own organization and institution. But tabletop exercises are great. Just mental rehearsals, standing around in a huddle and just going through and talking with each other and walking through the steps with each other of, okay, this is what we're about to do. These are the things that we need to think about. Does anybody have any other ideas or concerns before actually going and doing the thing? So it doesn't have to be a high fidelity, $100,000+ device that mimics a human being. And it can be a sack of potatoes. And I've had my own potato experience, so I really relate to the sweet potato. But starting first with the tabletop gives you, the wherewithal to just sit down and, look at the scope of the problem and let's map it out. It's great.
We recently partnered with a hospital in Brazil who was running who had a difficulty with an MCI, and they wanted to do some MCI trainings. And when we narrowed in on what the issue was, it was really how was space in their emergency department allocated. And in MCIs, it's very common to be overwhelmed at the beginning by low acuity patients because they get there before the high acuity patients. And so that was actually their key problem, is how do they keep low acuity patients out of the emergency department? And they created a Lego-based board game where they created a model of their department that was just on a mat, and then started to have Lego patients come in and Lego care team start to come in, and then you could see how crowded the space got. And that they were able to do a redo several times where the triage team got to be more effective at selecting the right patients to come back to rooms and the right patients to go somewhere else. And it was a inexpensive tabletop exercise that really belonged to them because it was specific to their department and how their hospital worked. And so it's just another example of like how we need to be creative in our partnerships to try to figure out what is the actual gap. How would they know that they're making strides towards being ready, and then meeting them at a place that's achievable for their goals.
And since we're talking and coming back to the idea of continuum of solutions in simulation, as well as the multiple departments and site locations, I want to go back one slide just in case. I want to make sure we didn't miss anything, because we were trying to make sure that we know that simulation is occasionally conducted reactively following an adverse event or a one-time intervention. So the question is, how do you design and implement simulation training to ensure that it delivers that lasting effect? And that's where we were touching on this, but I just want to make sure that all the other points were covered here. But I think they perhaps were. Once more, if you don't mind taking one quick glance.
So I think we have talked about spending more time partnering and less time designing, or I shouldn't say less time, but designing later in the process after we've done more time partnering and really understanding the risks, the way the leadership sees it and the way the frontline people see it. And then we have a co-creation activity using this readiness planning worksheet. And that's a boundary object that transfers the psychological ownership from the sim team to the unit. And this is part of what creates sustainability. And then we start to break down the curriculum plan using this concept of situational competencies first, and then the foundational skills that support the situational competency. And this structure really helps have a conversation, because we really struggle. I struggled in the past with being able to have an effective conversation with my partners who they saw us as a team that would run some sims and solve their problems. And I started to believe that my whole job was not taking on their problems as my problems. Their problems are their problems, and my job is to help facilitate solutions that they believe in and that they will find useful. And so these tools can really help us do that.
There's something in the chat and asking for a little bit more clarification on learning maps and boundaries to help with the buy-in. So could you expand on that a little bit more, please?
Yes, I'm looking at, so the readiness worksheet, they are going to see, if you look at the bottom of that page, we have the authors of that article. And is the article resourced on this page, on this PowerPoint?
I don't think so.
We will make sure
I'm
that
not
it is.
sure.
Okay.
We can
Yeah.
provide that.
So readiness planning as an innovation is the, I don't have the exact title, but it's something like that. And that's the author group. And there is an example of it in that article. So that will be that will be a resource. And then so learning maps and boundary objects. Okay. So Rox, you want me to take this and back me up and
Yeah.
clarify?
Yeah, go ahead. Sure.
So when we go visit a unit that is struggling, it can just feel so overwhelming to them. And oftentimes, my experience was the educator on the unit, often their only orientation was to their job was like receiving a folder with a bunch of PowerPoints in it. And now you're the nurse educator. And so our job can be to help them translate their challenges to some type of, like you call it, a learning map. And so the readiness planning worksheet can really help us with that, which is to start with, well, what are some situations that your team is just not yet ready for? And just asking that question and just writing them down is a great place to start. And then working backwards from there, if your team was going to be successful and ready to perform, to take care of a patient with a shoulder dystocia, if that's one of your situations, what are the foundational skills that they need? What skills go into that readiness? that situational readiness. And that those questions can really help to unpack what are the elements. Sometimes there's a rubric that you can find that does demonstrate the foundational skills from the standpoint of one profession. So sometimes they'll say like the nurse's job in X, Y, and Z is to do X, Y, and Z, and that can help find a list of the foundational skills. But because we're talking about multi-professional or trans-professional groups, we never find rubrics that are for
Work for
everyone.
everybody.
Right. So we're going to have to help coordinate the creation of the list. And that might involve an interprofessional conversation, or as was referenced earlier, it might involve actually running a sim and saying, okay, what does happen in the real world when we have a case like this, and helping to identify what those gaps are and what the steps are and what are the skills that are required. And when we run, yeah.
Go ahead.
I was just going to say, when we run that sim, our contractual relationship with the participants is we are here to help understand what you guys need. This is not a test, or this in itself isn't assessing you in any way. You're doing a favor for your department by helping to show where the learning gaps are. And we typically will get buy-in in that setting.
Yeah, and Lon, could you just give us a concrete example of a boundary object?
Oh,
For the
boundary object is the piece of paper that
Oh.
we use to have the conversation with. Yeah. So it's any object, or, in this case, it's often a digital artifact, right? It's just like a Google Doc or something that helps us to work together to understand each other's needs. And it's language is imperfect, and actually the same word means different things to different professions. And so we have to have a way to have the conversation around what do we mean by that. And so the document is the boundary object.
Very good.
And
Janet, go ahead.
I'm going to ask Helen to advance just one or two slides, because somebody in the chat is also asking for some other resources, and I thought I'd quickly allude to something so I can we'll pause here for just a moment, but I would like to hand it back to you, the two of you. Just for what it's worth, I just wanted, much of this discussion, Laerdal has been paying very close attention to in looking at more of a system approach and really leaning into healthcare quality improvement. And they have created a dedicated healthcare quality improvement, or HQI, resource page, where you'll find a lot of quick access to Laerdal's products, solutions, training tools, and other HQI-focused content all in one place. It's a great way to stay connected to the latest resources tailored towards your team. So there's a QR code there that you can follow, and I do believe that Helen is also going to put the URL in the chat, just because this really does tie in neatly to the way that you approach simulation as well, and it is a focus also at Laerdal. But in the next slide, what I really wanted to give you an opportunity, because it relates to some of the questions in the chat, is that the Center for Medical Simulation also has very valuable resources. And I would like to know, or give you an opportunity to explain a little bit more and share more with this audience. We have about 10 minutes, and I think this is still, we can have a few more moments for Q&A.
Okay, good, because I found that there's a conversation going back and forth in the chat that's highly interesting, that has to do with the laughing participant at a mannequin that's doing something weird that a normal human being would do in a different way. So I kind of want to get back to that. But Lon and I can walk through a few of these things. We have on our website a number of free materials that can be downloaded. Or we have links to where you can download an article if it's available for free elsewhere. And so please be comfortable going to our website and tooling around and seeing whatever you can find. There's also old webinars that we posted in the past. We have instructor training courses where we train the trainer, and advanced instructor training courses. We have a variety of teamwork training courses. The Center for Medical Simulation was founded on anesthesia crisis resource management team training, and labor and delivery team training came next. So we've expanded tremendously since then. So there's a whole variety of teamwork training that's out there that we do. Lon, you want to talk a little bit about coaching and other resources?
Yeah, so Jenny Rudolph and others provide focused coaching for individuals seeking to grow as leaders, and also for cohorts that have a project that they're trying to grow within their organization. I think to expand a little bit on the instructor training, I think Rox, how's this sound as a summary? We have a 1 week intensive introduction to being a simulation to being a simulationist that is focuses on design and debrief and partnership, and it's experiential. We do it in Boston, we do it online, and we do it in other places as well. And then we have an advanced version of that as well. And then also we have a fellowship program. I was a fellow here um, way back 2021, and seems like a long time ago. And that program is run by Roxanne, and it's phenomenal. And you participate in many of the programs, and that can be online fully. It can be hybrid, or it can be in person in Boston. And then the part of the organization that I work most in is teamwork training. So we run teamwork training programs, like Roxanne said, for anesthesia and OB. And then there's other ad hoc projects, I think is another way of putting it. So we also have relationships with schools, like and health systems, like we talked about in Brazil and across the US and otherwise globally, that are longitudinal relationships where we've partnered in order to promote the successful use of simulation within the organization to help the health system meet its needs.
We thank you for that discussion, and that's just wonderful, knowing how there are many other resources that are there. And as Helen advances, I'm going to just point out to something else in the chat. Advancing the slide, Helen, thank you, because this gives us a chance to answer a few things. But I would like to call out something that Alyssa has posted in there. There was a link to healthcare quality improvement overall, and it's also broken down into the maternity segment quite specifically, as well as a section for neonatal care in HQI in that space. So thank you very much for adding those links too, as well as Mama Ann. She's yes, when there are a variety of resources to get the learning across, and we know how effective and how much a high fidelity simulator like Mama Ann can really ease the burden and make it, break that verisimilitude and bring it forward with the believability and authenticity. So thank you for sharing that as well. But this would be a great time. I have maybe just a minute or two wrap up later, but this is a great time to hand this back to you, Dr. Gardner, and answer a couple of those questions. This is Q&A, and if you'd like to take any of those that you've seen in there, that'd be fantastic.
Yeah, I'm specifically referring to the chat line that Donna opened up about the student who was laughing at the mannequin mom who started seizing, and she just couldn't see the mannequin as a real patient. And then some colleagues who are participants here chimed in about the fiction contract and how that's discussed during the pre-brief before they get into the simulation, or maybe during the orientation of the day if it's a day-long program. And so I think that is where I would have gone in answering this question. In the moment, it is their experience and their interpretation, and I can't decide what's real for the participant, for the learner. So it is their experience. And to try to offset, it doesn't always work, but by having this discussion at the beginning of your session before you go into the simulated cases, or if they're coming back, just as a reminder to go through the importance of the fiction contract and behaving towards the mannequin patient as if you would a real patient, because more likely than not, you will find this real experience at some point in your career. And so having the opportunity to practice and manage a situation with a mannequin type patient or a standardized patient or a cardboard patient, whatever, or a sweet potato, if you approach it as a real situation, you will get more out of that whole experience. And we'll always have something to talk about in the debrief. There will always be things that arise that are relevant to real life and can be taken back to real clinical practice. So I find myself that having that discussion at the beginning makes a big difference. In our faculty, in our instructor training courses, we talk a lot about the fiction contract and the importance, or what is the importance of realism, and what does realism mean? It is what that person interprets it as, and you can't take that away from them. So it's not a point of argument. You just say, yeah, the mannequin, it's a cold device. It doesn't sweat. It doesn't cry. It doesn't really truly bleed. I can't tell you how many times I've tried to do an eclampsia scenario and the mannequin just wouldn't seize. But we had a nurse embedded in the situation, and the nurse was able to say, the patient's seizing, the patient's seizing. And so it kept people on track. So the mannequin, just sometimes they do things their own way. And so, improvising in some form or fashion and in the moment, and admitting at the very beginning that sometimes we work really hard to get these cases set up and running perfectly, and invariably something goes awry, and even the mannequin can die at the worst moment that we didn't plan for. So that happens. And part of that also involves the basic assumption, which is, we believe that everyone training here today is skilled, cares about doing their very best, and want to improve. And we as instructors hold that for the participants, and we ask each and every one of you to hold that for us. And I go further and I say, and please hold that for the mannequin, because mannequins sort of can go in a different direction that we never planned for. And so just bear that in mind. So sometimes that's enough. Yeah. And then there was another follow-up question that somebody had about, do any of your SimTechs talk for the mannequin? Oh, yes, we have our SimTechs talk and have a basic script of what they're supposed to say when they're approached. And sometimes I talk for the mannequin as the patient. So we all take turns talking as the mannequin as needed.
And thank you for that. I know we'll be able to get to a few other questions at a later time. But this has been absolutely outstanding. And I can't thank you enough, Dr. Setnick and Dr. Gardner, for your expertise and your insights. It has been truly valuable. Time just flies by when there's so much content that you can share. So we also would like to thank all of the attending, all of those on this webinar for attending and for your participation. That is most helpful. We greatly appreciate that. And thank you to SSH for providing this platform. So yes, a recording is going to be available, and that we will send it out also in an email, and it can also be found on the SSH website. So thank you so very much. We are exactly at the top of the hour, and we hope that you all will find great success in tackling these barriers. So the best to all of you. Thank you from Laerdal.
Thank you all.
Thank you, Janet.
We really appreciate your time and attention, and for your invitation to have us.